Welcome, fellow medical practitioners and students, to this explainer. Today we're tackling one of the most complex clinical challenges you'll face in practice: patients presenting with medically unexplained physical symptoms. Okay, let's dive into this and unpack these presentations. They often consume a massive amount of clinic time, and they demand a highly precise understanding of both diagnosis and management in detail, without just relying on a summary, so we can actively prevent patient harm. Our clinical grand rounds roadmap for today covers 4 specific areas. First, somatic symptom disorder. Second, illness anxiety disorder. Third, functional neurological symptom disorder. And fourth, factitious disorder. We're going to strictly cover the diagnostic criteria and management steps in detail.
Well, before we get into the exact criteria, we need to establish the conceptual framework for these presentations, which really hinges on the mechanism of symptom formation. It's kind of like a giant puzzle. On the unconscious side, you've got somatic symptom disorder, illness anxiety, and conversion disorder. These patients genuinely, truly believe they are physically ill. Contrast this with the conscious symptom formation side, specifically factitious disorder, where the patient is intentionally fabricating their symptoms, not for any external gain like money, but purely to assume the sick role.
Right, let's jump straight into Section 1, somatic symptom disorder, commonly referred to as SSD. Clinically, SSD has a prevalence of about 5 to 7%, and, we see it notably more often in women. The core feature here is an absolute fixation on an undetected disease. So when should you suspect it? Look for a few specific clinical red flags. First, there's a totally disproportionate focus on one or more physical symptoms. Second, and this is absolutely critical, they are completely unpersuaded by negative medical evidence. You can show them pristine MRI results, perfectly normal blood panels, and their conviction simply doesn't waver. And the third red flag? Symptom migration. You might successfully reassure a patient about, say, chest pain, only for them to come right back the very next week, completely fixated on a brand new, unexplained abdominal pain. That moving target is a massive diagnostic hint for us.
Now, what's really interesting about this slide is the strict chronological boundary set by the DSM-5. To actually confirm an SSD diagnosis, those somatic symptoms must be present for at least 6 continuous months. This mandatory duration is a lifesaver. It prevents us from misdiagnosing transient health anxiety as a chronic psychiatric disorder. Furthermore, the physical symptom has to be accompanied by excessive thoughts, feelings, or behaviors. We're talking severe preoccupation with the symptom's seriousness, chronically high anxiety, or literally an extraordinary amount of time and energy devoted entirely to the symptom.
Managing SSD requires some serious strategic discipline. While psychotherapy, especially relaxation training, and pharmacotherapy like TCAs for comorbid pain are definitely helpful, the real heavy lifting happens at the systemic care level. The absolute gold standard intervention? Assigning the patient a single primary care physician with regularly scheduled brief appointments. The rule-out logic here is absolutely crucial. You are actively protecting the patient from iatrogenic harm. By centralizing their care, you stop that endless cycle of referrals, redundant imaging, and totally unnecessary invasive procedures that actually just reinforce their pathology.
Moving right along to Section 2, illness anxiety disorder, which you historically probably know as hypochondriasis. In illness anxiety disorder, the fear itself becomes the primary pathology. We have a clinical vignette that perfectly captures the modern patient mindset. Addicted to internet searches about their feared illness, inferring the worst from information. What we're frequently seeing in practice today is basically cyberchondria. These patients are addicted to looking up their feared illness online, but instead of finding reassurance, they have this incredibly anxious, care-seeking mindset that consistently infers the absolute worst-case scenario from whatever medical information, or, let's be honest, misinformation they happen to find. And this brilliantly illustrates the subtle but crucial differential diagnosis between these two distinct disorders. It's such an easy trap for practitioners to fall into, but the rule is actually pretty straightforward. In somatic symptom disorder, the patient is actively burdened by the presence of significant, distressing physical symptoms. In illness anxiety disorder, on the other hand, physical symptoms are either completely absent or just extremely mild. The pathology in illness anxiety disorder is almost entirely driven by the sheer terror and preoccupation with the mere idea of being sick. Looking at the exact DSM-5 criteria for illness anxiety, we again see that strict 6-month duration requirement. The patient shows a high level of anxiety about their health, and they're easily alarmed by the slightest physiological change. But as practitioners, we have to be aware that this condition can manifest in two very distinct, maladaptive pathways.
The patient might exhibit excessive health-related behaviors, aggressively seeking care, hopping from specialist to specialist. Or, paradoxically, they might show maladaptive avoidance behaviors, where they completely refuse to see a doctor or even get a simple blood draw out of sheer terror that their worst fears are going to be confirmed. It's basically a fight or flight response.
So how do we treat this? For management, cognitive behavioral therapy, or CBT, is the definitive first-line intervention here. It allows us to help the patient rewire and restructure those catastrophic cognitive distortions they have about totally normal bodily sensations. Mindfulness and exposure therapy also yield really good results. Pharmacologically, if their anxiety is just debilitating, SSRIs are the preferred medical intervention to help lower that baseline autonomic arousal.
Okay, let's look at Section 3. Functional neurological symptom disorder, also commonly known as conversion disorder.
This condition is characterized by profound sensory or voluntary motor symptoms, things like blindness, paralysis, or non-epileptic seizures that are entirely incompatible with any known anatomical pathways. There's a classic psychiatric term you absolutely must know here: la belle indifférence. This describes a situation where a patient is surprisingly unconcerned about what appears to be a devastating physical impairment. I mean, if a patient presents with sudden paralysis of their legs, but they're describing it with the casual tone of someone discussing what to have for lunch, that paradoxical lack of concern is a major clinical pearl. It points directly to unconscious symptom formation as a response to psychological stress.
Let's move to and see how this builds a highly practical differential matrix specifically regarding seizures. Differentiating true epilepsy from psychogenic non-epileptic seizures, or pseudo-seizures, is a classic emergency neurology challenge. In pseudo-seizures, lateral tongue biting is almost always absent. If there is a bite, it's usually at the anterior. Urinary incontinence? Exceptionally rare. Postictal confusion is highly unlikely. And most objectively, your lab tests will show no post-seizure spike in prolactin levels, and you won't observe cyanosis because, well, there's no true respiratory compromise.
The DSM-5 criteria for conversion disorder really hinge on this exact discrepancy. Yes, the patient presents with altered voluntary motor or sensory function. But notice the second criterion carefully. You, the clinician, must actively prove through your physical examination that there is no correlation between the symptom and any recognized neurological or medical condition. It is an active demonstration of incompatibility. It's not merely a diagnosis of exclusion where we just couldn't find anything else.
Managing this depends heavily on your timeline. In the acute phase, trying direct psychological interpretation, basically telling the patient, hey, this is all in your head, is a massive clinical error. It just triggers severe resistance. What actually works is steadfast reassurance. You provide support, you validate their distress, and you gently reassure them that their neurological pathways are completely intact and the symptoms will resolve. Now, if the presentation becomes chronic, you have to step it up to an intensive, multimodal approach. We're talking hospitalization, physical therapy to prevent muscle atrophy, and even techniques like hypnosis.
Shifting gears now to our final disorder, Section 4, factitious disorder.
We are now crossing the line from unconscious psychological manifestations to the conscious, deliberate fabrication of clinical signs. So when do you suspect factitious disorder? The red flags here are highly paradoxical. The patient will often provide an inconsistent or sometimes impossibly complex medical history. Shockingly, and this is wild, they eagerly request painful, invasive surgical procedures. Who does that? They also have this uncanny ability to suddenly predict their own clinical deterioration the exact moment you mention discharging them. And frequently, these patients actually have a history of working in healthcare, which gives them the medical literacy they need to mimic specific diseases incredibly convincingly.
The DSM-5 criteria for factitious disorder demand that the patient actively falsifies physical or psychological signs, like literally contaminating a urine sample with blood, and purposely misleads the clinical team. But the absolutely critical distinction you have to make here is differentiating factitious disorder from malingering. In malingering, the patient lies for a tangible, external reward, financial compensation, evading law enforcement, that sort of thing. In factitious disorder, there is an absolute lack of external rewards. The sheer psychological need to occupy the sick role and receive medical attention is the entire driver.
So the crucial point is that managing factitious disorder relies heavily on interdisciplinary communication. You have to collaborate tightly with the entire care team so the patient can't split the providers or manipulate different departments against each other. You must strictly avoid ordering unnecessary procedures, because if you do, you're just being manipulated into causing direct iotroteric harm. Once fabrication is absolutely confirmed, confrontation is necessary, but it has to be done in a non-threatening, supportive manner, focusing on their underlying emotional distress rather than just purely accusing them of lying.
Which leaves us with a profound clinical challenge to reflect on today. When you have incontrovertible proof that a patient's symptoms are totally fabricated, how do you confront them without completely fracturing the therapeutic alliance? Because if you push too hard, the patient simply absconds and begins deceiving a whole new medical team at a different hospital. Navigating this requires a delicate balance of firm clinical boundaries and deep psychological tact. It truly is the ultimate test of the art of medical management.